Hello and welcome.
Huther and McCants.
Diarrhea.
The liver holds approximately 25% of cardiac output.
The exposure to a stressor, such as taking your Patho 332 final, stimulates the hypothalamus, Laura, top left, to release CRH, or corticotropin-releasing hormone, symbolized as the football. CRH then flows through the hypophyseal portal and stimulates the anterior pituitary gland, Natalie in the top right, which releases ACTH, adrenal corticotropin hormone, symbolized by the bouncy balls, which then flows through the bloodstream and stimulates the adrenal cortex, and initiates the release of both mineral and glucocorticoids, aldosterone and cortisol. When adequate amounts of these glucocorticoids are released, they inhibit CRH release at the hypothalamus, completing the negative feedback mechanism. When stimulated by a stressor, the hypothalamus releases CRH hormone, which stimulates the anterior pituitary gland to release ACTH hormone, which binds to the receptor site on the adrenal cortex. This stimulates the release of both mineral and glucocorticoids. Mineral corticoids, such as aldosterone, stimulate sodium and H2O retention, as well as increases patient blood pressure. Glucocorticoids, such as cortisol, the analogy BBIIG. The first B stands for increased blood pressure, resultant of alpha-1 receptor stimulus, and supplemented with mineral corticoids such as aldosterone, increase the patient's blood pressure. The second B is for bone formation inhibition, seen by the Pac-Man ghost eroding away uncontrolled. The third is I for anti-inflammatory, seen by the firefighter fighting the fire. Second I is decreased immune function, which is the inhibition of macrophage migration. And finally, the G is increased gluconeogenesis, lipolysis, and proteolysis, which results in increased blood glucose and subsequently increased insulin, resulting in cortisol-induced insulin resistance. As a last tidbit, the increased influx of sodium and H2O retention results in an excretion of both potassium and hydrogen ions and can result in both hypokalemia and metabolic alkalosis.
Exogenous glucocorticoids work to decrease inflammation and suppress the immune response. This is done by decreasing capillary permeability, decreasing migration of white blood cells, and decreasing fever by suppressing the release of pyretic agent interleukin-1 from white blood cell. Glucocorticoids also promote gluconeogenesis by increasing blood glucose and resulting insulin resistance, which can put the patient at risk for developing diabetes mellitus. Exogenous administration causes endogenous secretion to stop. Adverse effects of glucocorticoids include poor wound healing, emotional lability, psychosis, schizophrenia-like behaviors, hyperglycemia, osteoporosis, ecchymoses, fragility, hypertension due to vasoconstriction, and heart failure and fluid overload from mineralocorticoid receptor stimulation. Avoid abrupt cessation, which can result in adrenal insufficiency and may be life-threatening. Drugs should be administered in the morning to coincide with the body's normal secretion of cortisol. Periods of stress may require supplemental systemic glucocorticoids. Exogenous mineralocorticoids, such as fludrocortisone, work by causing sodium reabsorption, leading to water retention and potassium and hydrogen excretion. So we can see here increased sodium, decreased potassium, and decreased hydrogen ions all lead to metabolic alkalosis.
Cushing's syndrome is characteristic of hypersecretion from the adrenal cortex, specifically excessive cortisol release. The primary pathophysiological cause of this can be from chronic exogenous steroidal use, seen in cases of COPD or organ transplant, pituitary adenoma, which is a tumor on the pituitary gland, symbolized by the fantastic sombrero, and a paraneoplastic ACTH tumor, which is a carcinoma usually located in the lungs that secretes ACTH. In this example, there is a pituitary adenoma which releases excessive ACTH independently of the hypothalamus. This independent function of the pituitary adenoma results in the inhibition of negative feedback mechanism and results in the increased serum cortisol levels. Clinical manifestations for Cushing's syndrome can be characterized by muscle weakness or thinning of the extremities, moon face, buffalo hump, and truncal obesity, which is the lipogenesis and increased fat storage in the face, neck, and thoracic regions, hirsutism, easily bruised, and the purple striae. Although the treatment for Cushing's syndrome is contingent upon causation, in this example we show the surgical eradication of the pituitary adenoma. This process can be completed both surgically or via radiation.
To treat Cushing's, you need to treat the clinical manifestations: hypertension with antihypertensives, hypokalemia with potassium supplementation, hyperglycemia and diabetes with antidiabetics, and osteoporosis. All of these will treat the metabolic alkalosis.
Addisons disease is an autoimmune disease that leads to the destruction of the adrenal cortical cells. This cellular destruction causes an inability to synthesize adequate amounts of cortisol and results in an increase in serum ACTH levels due to a loss of the negative feedback mechanism. In this example, the hypothalamus is functioning correctly, as is the pituitary gland, but the unresponsive adrenal gland is hyposecreting cortisol, which results in the minimal regulation of the negative feedback mechanism. In turn, this results in hypersecretion of ACTH in desperate attempts to stimulate the adrenal cortex, seen by the hundreds of bounty balls, only to elicit a minuscule release of cortisol, also known as Addisons disease.
The clinical manifestations associated with Addison's do not appear until about 90% of total adrenocortical tissue has been destroyed. At first, a patient may experience symptoms such as weakness and fatigue, as well as hyperpigmentation or vitiligo. As the disease progresses, these symptoms worsen to the extent of anorexia, weight loss, and fatigue. Other common manifestations include excessive nausea, vomiting, and
Diarrhea.
A person dealing with Addison's will typically have hyperkalemia, increased BUN levels, and hyponatremia. Treatment of Addison's disease includes lifetime glucocorticoid and possible mineralocorticoid replacement therapy, along with dietary modifications of increased sodium and fluid intake. Common glucocorticoids used in the treatment of Addison's disease are hydrocortisone, which is preferred for its additional mineralocorticoid properties, dexamethasone, which comes in a vial but is best absorbed orally but also has a very bad taste, solumedrol, and prednisone. On the mineralocorticoid side, fludrocortisone is the preferred medication as it acts as an exogenous form of aldosterone.
Adrenal crisis is defined as a sudden insufficiency of adrenal hormone secretion and synthesis. This results from abrupt cessation of glucocorticoids or inadequate stress dosing for febrile illness, stress, trauma, or surgery.
Natalie, are you okay? Are you okay, Natalie? She appears to be hypotensive. I think she's in vascular collapse and hypovolemic shock. We need to call the ambulance right away. We need D5 normal saline and high doses of dexamethasone.
I got the dexamethasone.
Thank you. Treatment includes high dosing of glucocorticoids to rectify the abnormal electrolyte levels as well as the potential metabolic imbalances. The reestablishment of normal glucocorticoid levels can be achieved with the following medications: hydrocortisone, dexamethasone, solumedrol, and prednisone. Fluids are necessary for rehydration and can also be utilized to help balance and regulate potential electrolyte insufficiencies such as hyponatremia, hypercalcemia, hyperkalemia, and potentially hypoglycemia.
Oh my god.
She appears to be hypotensive and in hypovolemic shock. That's